I would like to move now, if I may, to the item on governance for clinical commissioning groups, and to take with that the paper on authorisation of clinical commissioning groups, and to ask Chief Executive to introduce the two.
Thank you. I mean, these are two really important documents, but neither of them will I think, come as any surprise either to the service or to ourselves. It was something that we had to get on and do as part of the preparation for setting up of the board and the clinical commissioning groups, and now's the time, I think, in a sense, for the board to put its marker on them and to make them our official policy and guidance. They have changed a bit as we've been through that process, and I'll mention what that is. The first one is around governance, and I think one of the things that's kind of made this whole process, I think, different to any, certainly, of the changes that I've been involved in the NHS over the last period, is the way in which it's been built up from the service. And as you know, clinical commissioning groups were announced, GP consortia originally were announced in, I think, May of 2010. We had a whole set of work around them. We had the listening exercise. They start to morph into the ideas of clinical commissioning groups. And what's been happening around the country is that groups of general practitioners and some other professionals have been working together to come up with a set of arrangements. That's very unusual. Normally in NHS terms, we would start off with a map and a pencil, and we will be drawing geographic arrangements around them. So these are very bottom-up organisations, and really do benefit, I think, from that in terms of the way that they're started to create services around their individual communities. So that's been going on. We come into the end of that process now, in a sense, where most of the clinical commissioning groups now have agreed their constituent practices and have agreed the geographies. I think over 95% are in that position now, and I think we're already seeing in the service the benefits of some of the work that they are doing. There are lots of examples around the country, and just at a high level, we know that already about half of the commissioning spend that will go to clinical commissioning groups after 2013 has already been delegated to them under a variety of schemes from PCT. So they're actually starting now to learn how to put clinical commissioning into practice, which I think is great. And no doubt many people know the really good examples around the country, not everywhere, but around the country. And our ambition here is that by the 1st of April, that all clinical commissioning groups will be taking on that delegated responsibility, so that we can use 12-13 to learn and to develop their skills. But of course, what's really important in all of that is that we get good governance around these organisations, which are different to the kinds of organisations that we've been involved in before in the NHS. These are not a straightforward organisation. They are a combination of a number of practices coming together across a geography. And as such, we've tried to be very flexible about the kind of governance arrangements that you put in place. And in a sense, they have developed and emerged over the last few months. And the first document is really in response to both our requirements to ensure that when we go through the process we have a set of organisations which are properly governed, but also the clinical commissioning groups themselves are saying, can you give us some help and support and advice on how to do all of this? So that's the first document around effective governance, and we've tried to be as flexible as we possibly can. Bear in mind the kind of innovative nature of these organisations, and we've spent a lot of time trying to get that balance right. The balance between giving people the flexibility to do something that suits them locally, but also to ensure that they deliver good governance. And if you think about this document compared with the previous one that came out, we've strengthened the bit around patient and public involvement. We think that's an important part. We've set out much clearer, I think, the importance of the Nolan principles in terms of the way they conduct their business. We've done more work around how we can connect clinical governance across the arrangements, and we've thought particularly about how governance operates when, in many occasions, clinical commissioning groups will have to work together collaboratively across the system to develop services for patients. So I think as a kind of basis, this is a really important and powerful document to go out officially to clinical commissioning groups so that they can get on and get their governance in place, so that they can respond, in a sense, to the second document, which is the one on towards authorization, based on the towards authorization. And again, since May 2010, you can see the way in which we've worked with clinical commissioning groups, we've worked with various organisations around the country, and come up with a set of authorisation principles and detail, which I think take things forward significantly. If you remember, at the beginning of this process, we talked about whether what was the issue around earned autonomy. So this kind of model, this idea that people, by their actions, by their building up a track record, by engaging, would give us a sense of whether they were capable of taking on the major responsibilities of commissioning in 2013. So underpinning all of this is this idea of earned autonomy, which I think is really important. And the second thing is that authorisation should not be seen as the beginning and end of a process. We need to take people beyond authorisation. So the idea that you don't, in terms of development of a CCG, we don't work with CCGs to development to get them over the barrier, the bar of authorisation, but actually we can inspire and lead them to a much better place, a more ambitious place for their activities. So increasingly authorisation, instead of seeing something that you pass and fail, is seen as I think what is described in the jargon as a maturity model that we can use across the whole of our relationships with clinical commissioning groups. And this document kind of sets out both the ambition that we have to help clinical commissioning groups become the best they can be, but also the clear responsibilities we have to ensure both ourselves and the NHS and the population generally that we've got organisations that are capable of taking on these major responsibilities. So that, in a sense, is the towards authorisation document. And these two things together, I think, give clinical commissioning groups almost everything that they need from us in order to take their organisations forward. I commend them to the board.
Well, thank you, David, for that very clear exposition, and indeed for the energy and the ambition that it exudes. And as I understand it, what we will do with the papers that we're approving for publication is to give the clinical commissioning groups as much as possible of the guidance that we feel they will need, and it's guidance to which we will subscribe throughout the coming period. In other words, this is not something that's going to chop and change. These are the clear principles. They're not going to be flooded with additional guidance. The paper on authorisation requires some details to be completed once the legislation's through and the regulations are in place, so it can't be finalised until July. Yeah. However, at this stage it can go out as a draft paper so that people are clear of the direction of travel. Let me ask my colleagues on the board for further questions and comments. Kieran, for you.
I think David anticipated the thing I was going to say, which is it's a process, not an event, and authorisation, and what can we do to make sure that the learning from a good authorisation process in one place, where either the process is good or somebody sees something which is very innovative, gets carried to all the other 200 and whatever authorisations which are going to go on.
Yeah, no, I think that's it's a really good point. I think we can learn some of the lessons from other similar kinds of processes that we've took forward in the past, and what we think is that, I mean, first of all, the authorisation process, the document you've got in front of you today, has been developed with CCGs across the country. There's been quite a lot of work of people trying to think all of this through, which I think gives it a good base. But the real issue then is how do we turn that into a reality? And the thing we're thinking very carefully about, and we haven't come to a final conclusion yet, is about what kind of process we would use to take it forward. So if you take, for example, as part of this process, there would be a site visit. where we would look at all the evidence that had been produced around that organisation. And I think we're thinking that on that site visit you'd have people from other CCGs who could come along, who'd been through the process, who could help and support, and some who were going to be involved in the process in the future. So in that sense you build a set of understanding and knowledge about the process, which I think can spread really very, very quickly. It is, though, I have to say, logistically a very, very difficult, complicated thing to do if you think about the numbers that we've got to get through in the time that we have. But I think if we approach it in that, what I describe as the developmental way, I think we'll get much better value out of it than essentially asking for 14 lever arch files and a box to tick.
Yeah. Nice.
Which is not what I'm suggesting, by the way, just in case anybody doubts that.
That's the default position.
No, that's absolutely not what.
Exactly. Yeah, did he?
Yes. No. I congratulate the team on the work and the amendments to the documents following feedback. I think the point I would make on the first set is it sets out the principles very well. I think absolutely immersed in that is the style of leadership, and it comes back to again the ways of working, the role of the chair, the interaction of the chair with the other members of the authority, and we need to instill the fact that this is not just structure; it's about behaviour. It's about the way in which these authorities work, and then that brings you on to the authorisation process. And I very much support David's statement that if we were to look at the authorisation process as a gate which was around ticking various boxes, I suspect we would not get the sense that this is that we need to get from being on the ground, from visiting, from having conversations with the leadership about how it feels and how they are going about the process of creating the CCGs and creating a sustainable governance structure. So I think we will spend and have to spend quite a lot of time, despite the fact we have a relatively short elapsed time, on engaging on the ground with the commissioning group leadership to get that sense of how things are going rather than just receive documentation. But very supportive.
I agree with all of that. I mean, it will be a hugely resource-intensive exercise, but probably no more so than doing extensive box ticking and using it simply as a gateway, because it's a much more iterative process and a learning process across the country. I mean, I think what we're looking at is both evolutionary and revolutionary. It's evolutionary in the sense that clinical commissioning through the CCGs is already developing, and we are already seeing some beneficial consequences across the country as a whole. As David keeps reminding me, causality isn't entirely established. But that secondly, it is a very dramatic change to the traditional model of doing business within the NHS, and for that reason we are learning as much about it as we go along as will be the CCGs with which we're engaged. So I think an open and fluid process, as is proposed in these papers, is essential, and equally essential that we give at this stage the clearest possible guidance, but it is guidance rather than prescription to the CCGs as they develop. Could I ask whether colleagues on the board have further questions or comments, or whether you are willing to do the following? First of all, to approve the publication of the paper on creating responsible and accountable clinical commissioning groups and the two technical appendices, which I detect general warmth and assent to around the table. And then secondly, in relation to the authorisation process, note the progress that's already been made with the clinical commissioning groups and formally adopt the document that's been presented to us today. Alongside that, also agreeing the future work plan and noting the key risks that have been identified in the actions as proposed to manage them. But bearing in mind, as I said at the very outset, that all of this is subject to the passage of the Health and Social Care Bill. So we're in the transitional period unless and until the Act receives royal assent.